Hello and welcome to this author interview and conversations with Dr. Bachner. This indeed is Howard Bachner, editor-in-chief of JAMA, and I'm here with Nicholas Christakis. Welcome, Nicholas.
Welcome. Thank you for having me, Howard.
So Nicholas is the Sterling Professor of Social and Natural Sciences, Internal Medicine and Biomedical Engineering at Yale, one of Yale's highest honors, Sterling Professor of Social and Natural Sciences. Let me explain why we're talking with Nicholas today. I think people know most of our conversations around the pandemic have been around largely the acute management issues, and today we're changing a bit. Over his career, Nicholas has tried to combine the fields of both medicine and sociology. In 2010, he and his colleagues initiated a program of research to deploy social networks to improve health and other social phenomena. And he's worked in the fields of network science and biosocial science, evolutionary biology, sociobiology, behavioral genetics, and epidemiology. And I thought it'd be nice to take a different view of what's happened to date, and then with Nicholas to look around the corner about what may happen in July, August, and September. So, Nicholas, in your lens, what's the pandemic been like so far?
Well, I think the closest analog that I can see to this pandemic, although it was caused by a different pathogen, was the 1957 pandemic. So if you just pick a few parameters that can describe a pandemic disease, for example, you pick the attack rate, which is the fraction of people that get infected. With previous pandemics, and it's important to mention this, that with epidemic and pandemic disease, not everyone in a population gets infected. For example, the 1957 pandemic, we know from serological studies that were done after it was over that about 40% of Americans had been exposed to the pathogen in 57.
The pathogen being, sorry?
That was another ribovirus back then. And then if you look at all the pandemics that we've had over the last 100 years, including the 1918 pandemic, which of course was the big one, that killed the most people around the world, you can compute some other numbers that describe them. For example, you can compute the so-called case fatality rate or the infection fatality rate. The infection fatality rate is the fraction of people who are infected who die. The case fatality rate is the fraction of people who, let's say, have symptoms or who come to medical attention who die. About half the people with this particular pathogen that we're dealing with now are asymptomatic. The rest have some symptoms or come to medical attention. So if you look at the case fatality rate of this pathogen, there's a range of estimates, but I think it's probably going to be between 0.5% and 1%. So it's between 5 and 10 times as deadly as seasonal influenza, which kills about 0.1% of its victims on average. And so you can plot the case fatality rate of all the epidemics. So, for example, if you look at the H1N1 epidemic from 2009, one of the reasons that one petered out was it wasn't very fatal, so we didn't really notice it. It was about half as deadly as the flu. So 0.05% who got that condition might have died from it. And then conversely, if you look at the Sars epidemic of 2003, the first Sars epidemic, another coronavirus, that one killed about 10% of its victims. So that was 10 times as deadly as the flu and much deadlier than the current epidemic. And that's also one of the reasons it petered out, because it killed its victims before they could spread it. So we have in this pathogen, we have a pathogen that has a case fatality rate that's sort of in between those extremes. And then we can also compute a third number. So the attack rate, the case fatality rate, and a third number to compute is the reproductive rate, the effective reproductive rate, similar to the R0, the R0. And that's the number of new cases you get in a kind of steady state of the pandemic for each old case, assuming typical levels of social mixing and typical sort of environmental conditions. And we estimate that number is about 2.5 to 3 for COVID-19. So if you make a little plot of the fatality rate, the case fatality rate on the x-axis, let's say, and the transmissibility, the RE on the y-axis, and you plot all the pandemics that have occurred in the last 100 years, up here in the upper right, you have 1918, very deadly, very transmissible. And then you have all the others, down here at the bottom, you might have not so deadly, not so transmissible. And right in the middle, you have the 1957 pandemic, intermediate fatality, intermediate transmissibility, and close to it, we don't know exactly. It depends on we'll learn soon as we get more information. You have this one, I think. So I think this is a very rare, once every 50 years event that we are experiencing right now, that many people had forecast and expressed concern would come. And I think that's, if I look for historical analogs, that's the one that I think we are closest to, is the 57 pandemic.
Has the world being a smaller place, someone told me that 500,000 people traveled back from China to the United States between January 1 and mid-February. Has the world been a smaller place really impacted the spread of the disease?
Yeah, I think there's no doubt that the speed of movement and the numbers of people moving have effects of the kind you're outlining. But it's important to mention that the 1957 pandemic also began in China, then moved to Hong Kong, where it afflicted about 10% of the population at the time. 250,000 Hong Kong Chinese were infected and known to be infected. There was a little article in the New York Times on page 3 on a particular date that described, epidemic in Hong Kong. And then not long after, it was in Rhode Island, because there was steamship traffic and other ways that people moved around the earth. The virus could spread, of course, person to person overland, or people could relocate. And then there was an outbreak in Rhode Island, and then there were outbreaks in California, and then it spread across the entire country in 57. So it is the case that things spread more rapidly now. It is the case that there are linkages because of air travel between places that otherwise previously would have been more difficult to make the connections between. But it's not the case that we didn't have pandemics before. I mean, 1918 was before modern air travel altogether. So these things, have occurred in the past. And I should say, one of the interesting things to me is that, plagues are a feature of the human experience. There's a plague in Athens in 430 BC that Thucydides writes about. And Thucydides talks about how healthcare workers were more likely to die. He says the doctors are ignorant of what causes it, he writes, but they're dying because they're tending for the sick. And so even this feature that, we're so disturbed, appropriately we are disturbed by the toll the epidemic is taking right now on healthcare workers, on frontline healthcare workers. But even this feature has been known for a very long time. And many listeners will remember those famous medieval European costumes that the plague doctors wore with those enormous beaked, right, with the glass, and there was personal protective equipment, that they had.
I hadn't thought about it.
Yeah. So, these features that we are experiencing and are rightly disturbed by are nevertheless features that have been experienced by our forebears and confronted. So yes, there's a history to this. There's a way in which these epidemics have come before.
What's surprising you so far about this pandemic?
Well, I began to pay attention to this. I may have seen some reports in January or read in the news. I honestly don't remember. But January 25th or 24th, I was contacted by some Chinese colleagues with whom I've been doing research for a long time on different sorts of network sort of studies, because my lab does a bunch of things. But one of the things we do is we study human social interactions and social networks, face-to-face networks, not just online networks. And we do also some genomics and some work on the microbiome. So we have a heterogeneous set of interests in my lab. So I'd been working with this group for some time, and they contacted me January 25th, and they said, we have access to these interesting data that could shed light on what's happening with the epidemic in China. So we began a collaboration, and which we've continued to this day, working on a number of projects, some of which are under embargo, as you can imagine. And anyway, so I began to pay serious attention. And I would say by early February, I knew it was going to be a pandemic. I mean, it was very clear to me. Part of the reason I came to that conclusion was that I had began to study the Chinese response. And so, for example, I became aware of the fact that the Chinese had passed regulations or implemented regulations that kept 930 million Chinese citizens, people, under a form of home confinement beginning January the 25th. So a billion, and they're still under home confinement. 1 billion people have been at home since January the 25th. And And I did not think that the Chinese would have taken this action idly. I began to be aware that they were taking this very extreme set of measures that, of course, were abetted by their authoritarian form of government and their long history of collectivist culture. People were willing to comply in some sense. They would not have taken such an extreme action unless they perceived the threat to be very severe. So that got my attention. I'm like watching what's happening in China and saying, this is a significant problem. And furthermore, there's no reason to imagine it will stay in China. So the WHO report that was released in mid-January, I think, that suggested there might not be human-to-human transmission, that was clearly implausible. And so then to study the topic. So we began a series of projects. By the end of February, we were doing quite a few things related to this. And then in early March, I got very upset with what I perceived to be the lack of leadership in our politicians, who didn't seem to be taking the threat seriously. And so at the time, I had a very small Twitter following of like 50,000 people. And I decided I would just start sending out basic information about pandemics, and basic epidemiology, talking about incubation period and latency and pandemic disease and risk factors and stuff like that. And to my amazement, there was a lot of hunger for this type of basic information, and so a lot of those tweets went viral, and I got tens of millions of views of these things, and so then I decided that I might be able to be more useful if I try to accept some invitations to speak to the media. I mean, I know I'm speaking now to a very sophisticated audience, but even this, for example, to try to advance the public understanding of science about, what was the nature of the threat we were facing. For example, early in March, we may not remember, school closures was a big deal. There was a fantastic paper published in JAMA, which has now been resurrected as a classic paper on the 1918 epidemic by Markle.
Right,
yeah.
It was resurrected.
Yes. All of a sudden, this paper has a huge relevance, and it was a beautiful paper of 43 cities and looking at school closures and the banning of public gatherings and the effect that they had, using a kind of natural experiment that looked at intercity variation. It was a collaboration between historians and epidemiologists, a lot of collection of historical data, and then application of epidemiological methods. And so I, repopularized this paper and saying, look, what can we learn from the 19 epidemic? And there was there was a lot of interest in this, and I not just because of that paper, but that paper looked at school closures, but there were a number of other papers that had looked at school closures in Japan and Italy during previous pandemics. And for these reasons, I sort of was advocating for school closures early in March as an effective tool that we could use to try to slow the spread of this disease so that we could get our defenses built, by flattening the curve so we could prepare ourselves for what was going to happen. So anyway, so that's how I have come to spend so much of my time on coronavirus, in the last few months. Now, I still have other things we're doing in the laboratory and other obligations, but, a lot of my attention right now is on this challenge.
Taiwan has done reasonably well. Singapore, Korea.
Another good paper in JAMA on the Taiwanese response.
Yeah, I know. Yeah, by Jason Wang. Now there they have a smaller country. John Wang wrote about Singapore. We haven't had as much from Korea. Mm-hmm. I'm sure you look at those countries and those data and go, there were lessons for us to learn, and we missed them. Do you have a sense of what those lessons were?
Well, I think I have a bit of a contrarian take on this. So there is no doubt that the South Koreans and the Taiwanese and the Singaporeans, although they're a little bit of a special case, they're tiny and a bit more authoritarian. But Taiwan and South Korea are kind of rich democracies and large. Not as big as we are, but goodly sized countries. And Japan is interesting. What's happening in Japan too? They were devastated by the SARS pandemic in 2003, and really prepared themselves for this. In fact, the vice president of Taiwan was a key figure, previously health minister, I believe, in coping with SARS. So he he had personal experience, like a politician with personal experience and background in this, a scientist. Even in China, in mainland China, by the middle of January, the central government in China had sent an expert from the previous SARS epidemic to Wuhan, and I am told that he took a look at what was happening and recognized immediately the seriousness of the problem. Then the vice premier of China was put in charge by the end of January, and the central government of China was taking all the serious actions that we discussed pretty quickly after a bad start where they tried to and I actually want to make a point about this right now because I feel strongly about this. So Dr. Wenliang Li in early December noticed a doctor in Wuhan, a young doctor, notices that lots of his patients are having an uncommon kind of ARDS. They're dying quickly. They have a glassy appearance on radiography of their lungs. He recognizes there's some unusual pneumonia. He shares on private social media with his friends, other clinicians, what he's observing. And eventually this gets to the attention of the authorities, and he's called in and accused of rumor mongering and told to recant his observations. This doctor eventually dies of COVID, as many other healthcare workers have in China. He's now a bit of a national hero in China because he was trying to sound the alarm about what was happening. And I'm beginning to see, although the circumstances are very different, I understand that's a government function and that it's an authoritarian government, but I'm seeing hospitals and healthcare systems in our country, which I don't need to name because you can search for them, that are clamping down on their doctors and healthcare workers and saying you should not speak to the media unless you have approval. You can't post on social media anything you observe in the hospital. We'll fire you if you do this. And if there's any time not to be firing doctors and nurses, it's during the pandemic. And furthermore, it's un-American. And furthermore, if we're going to beat this thing, we're not going to beat it with silence. I mean, we have to have free and open communication. It is the wrong strategy to prevent healthcare workers from expressing themselves, even if occasionally they say embarrassing things. The proper strategy, if your healthcare workers are complaining about the lack of personal protective equipment or they're noticing some kind of dysfunction and they're sharing it, the proper strategy is a forthright response. This is true, we're going to fix it, or it's false, and here's why it's false. Not to send encyclicals to the faculty of a university or the staff of a hospital and saying we're going to fire you if you talk about what's happening here. That's just completely wrong in my view. Anyway, so the same thing. So China also, like Taiwan, had a senior figure who was familiar with this, and the Taiwanese got their act together extremely quickly. They had testing. They had a tradition of obedient response to government directives. The South Koreans testing very fast. Contact tracing initially, which is possible when there are fewer numbers. Self-isolation that people obeyed, and sort of self-quarantine measures and the like. And so I think there were many aspects to the South Korean response that were, and they were of course closer to the front. To China, they had more rapid intelligence about it even than we did, although we knew about it. The president of the United States was briefed about this in the middle of January, we know now. And many, I think many experts in this country, scientists, people, epidemiologists, people who study pandemic disease, they all knew what was coming. I wish I could, I'm going to bend over here to just grab something. 1 second.
Sure.
You can get a book called The National Strategy for Influenza Pandemics. I mean, there are many books with this title. This is not a shockingly new thing. I mean, we know what to do, and many people knew it was coming. So the Taiwanese and the South Koreans, I think, did many things right, and we missed the opportunity to get our ducks in order. But I'm hopeful that America, like Winston Churchill said during the Second World War, America always does the right thing after having exhausted all other options. So, I think, we will get there, I hope.
So we're moving into April. What do you think the next 2-3 months look like, Nicholas?
Well, I think they're going to be bad, unfortunately. I don't think we adopted. Look, here's the thing. The 1957 pandemic killed 110,000 people before it was over the course of a couple of years, or 115,000. And the population at the time in the country was 170,000, so about half as much. So that would be
170 million, but
million. I'm sorry. Yes,
yeah.
Thank you. There's been a lot of confusion about millions and thousands lately, and I don't want to. I don't want to join that club.
I'll make sure we're good on the zeros.
Exactly. Yes, exactly. We're doing the correct division.
Right.
Yes. So, yeah, 170 million Americans, about back then 115,000 deaths approximately from the 1957 pandemic. So that'd be about 250,000 people now, which would, put it in the top 3 or 4 killers in this country. It was about half as deadly as cancer in 1957. So, and the end game here for this disease is the current one we're facing is that it's going to become endemic. It's going to become like the flu or like the cold. It's a new pathogen has been introduced into our species. It's going to circulate in us. And eventually we will get either a vaccine or herd immunity or both. And it's going to kill some people. Hopefully not a lot, but probably a goodly number. And, I think it's quite likely that a couple of 100,000 Americans, possibly more. I mean, there are a range of outcomes we don't know.
Yeah.
Could be 100,000, could be 200, could be 3, could be 400. We don't know where it's going to be. It depends on a lot of still unknown parameters. And part of the problem is that we're flying blind. We don't have all the data we need because we haven't done the studies we need. What we really need right now is a large, simple random sample, maybe with some oversampling in certain areas of Americans that are administered serological tests for have they been exposed or not. So we need to do that. But I'll come back to that. But the end game is that this disease is going to become endemic in us, and so people are going to die. And the point of flattening the curve is to reduce the intensity of death at any given moment, so that we can minimize the number of deaths, so that our healthcare system can take care of people and our supply chains can operate. And if we push some of those deaths out into the future by flattening the curve, maybe some of those people will get sick at a time when we've invented a vaccine or better medicine, so we'll prevent the deaths. So this reduction, this flattening the curve idea that's very correctly very popular right now, the point of it is not only to get our healthcare system working, but also to reduce, hopefully, ultimately the number of deaths. But there still will be a lot of deaths, and they are going to come, and they're going to still keep coming. I think Florida is going to have a serious problem in a few weeks. And Louisiana is already beginning to have a problem. And right now, it's on our major coastal cities plus Detroit, but the rest of the nation is not far behind. So yes, I think we're in for a very rocky few weeks, most likely.
I think one of the things you said likely will make some of our viewers nervous. A vaccine is a year away at the earliest.
Yeah,
and even then, it may not be that effective. Flu vaccine is not that effective.
Yes.
So do you begin to think at some point of more exposure for people, or will that happen naturally? I don't want to advocate for the so-called varicella parties, the chickenpox parties of the 70s and 80s, but is there a time when you begin to expose greater and greater portions of the population?
Yeah, so I think there's some modeling that's been done by Mark Lipshitz's group at Harvard School of Public Health, and I much admire Mark's contributions to the current pandemic. That stuttering social distancing is better than turning it all on. So what the Chinese have succeeded in doing is stopping the spread of the virus. They haven't eradicated it. It's going to come back to China. And there are going to be multiple waves in the United States. We're just at the beginning of the first wave of this thing. And so by stuttering social distancing, like turning it on and off, you kind of, if let's say we flatten the curve now and we get our defenses up and our healthcare system is working and we learn a little bit better about how to treat the disease and we sort out clinically like what are the optimal strategies, we get the American public ready for the kinds of sacrifices they're going to make, we do all of that stuff. Then we kind of relax the constraints a little bit. People will go out and mix and they're going to get the disease naturally, and most of them won't have any symptoms, or if they have them, they'll be mild and they'll be immune. And as we build up the number of immune people in our population, as people understand how herd immunity works, when you have a network of people, every dot's a person and the lines are relationships between two people. Imagine a network with little periphery and a center of densely connected people. If you start putting immune people in this network, in this graph, they can begin to block the paths that the pathogen would take through the network. And the more immune people you get, the better, blocking more paths. And then some of us who are not immune don't get the germ because all our friends are immune. So they can't give it to me because they're immune, and so I'm not immune, but I don't get it. And so that's the end game is herd immunity, and one way or the other. Either we get vaccinated or we acquire it naturally, and just sheltering in our homes forever is not, in this case, likely to fix the problem. I suppose theoretically, if we sheltered in home long enough and with enough cleanliness that we completely eradicated, like polio, like a smallpox, or like we're trying to do now with polio, if we do it right and eventually get no free living pathogen, then maybe we could win and eradicate it. But that's not what's going to happen.
Yeah, buying time. I mean, we don't have to go over the tragedy of testing in the U.S., which has just created a logistic and organizational nightmare for hospitals. And it needs to be rapid testing, not a day or 2 or 3 days.
Or 5 days.
Yeah, patients need to walk into a hospital, and within hours, the care team needs to know who are they taking. They're taking care of. So that as long as we buy a few more weeks, I'm hoping that will help hospitals better align their healthcare personnel with the needs of the clinical group.
Well, we also have to test. We also need serological testing for healthcare workers because we need to know if they're immune. Some of them, and that makes a huge difference to morale, right? Like if I know that I'm immune, I'll still wear the equipment, but it's a different philosophy now. When I'm going to see patients, I can relax a little bit. I can do the intubations. I'm the guy that's doing the intubations. It's totally different.
Right. I think the next series of papers, there's a number of ongoing clinical trials. We're trying to recruit some of them in the JAMA. But I think the serological testing, the IgG, IgM, convalescent titers, we had just published that paper as a therapy, but it also becomes important for other reasons.
Oh, yeah. Has anyone done convalescent therapy already for this disease?
There's been 1 or 2 reports from China, but no one has really seen high-quality data. And it may come out of Italy first because they're ahead of us. But I would expect New York City. There's, good labs beginning to do serologic testing.
I know the serology test exists, but I'm saying convalescent serum.
Oh, no, convalescent serum, no. We had the 5K series, but now there's some clinical trials that are already going on. Since that's time-honored for a century or more.
Yes.
It'll be interesting to see if it works. When you look at the summer months, before we even get to the fall, I have no idea what's going to happen with colleges or schools. They may be closed for this academic year. But can you see some relaxation in some portions of the country of this kind of social distancing as we move into the late spring, early summer?
Well, if we prepared the public for what is happening, we got the personal protective equipment, the medical staff, the testing. We got all our defenses up. Just by chance alone, there's going to be variation. Even with previous pandemics, not every part of the country was affected equally. So some parts it's just stochastic. Some parts will be more affected than others. There'll be a distribution in intensity of heavily affected and not so heavily affected, and then average effects. And then furthermore, some of the variants will be explainable. Maybe parts of the country with lower population density, they're going to be less likely to be as affected. Or maybe the weather will play a small role. I don't think so, but maybe it will. Or maybe the something about the healthcare system in that particular part of the country, or who knows. So there'll be some part of the variance will be explained by some causal factors. Or maybe, for example, I'm watching with great interest the difference between Kentucky and Tennessee, where the governor of Kentucky more promptly instituted various physical distancing measures. And Kentucky seems to be doing much better than Tennessee in terms of epidemic growth. Tennessee was a couple of weeks later before they did the right thing for various reasons. So we're going to see some differences from place to place that reflect the actions that were taken by the citizenry, that reflect various natural features of the environment, and then just some chance. So those parts of the country that are less affected, of course, they should be stood up earlier with vigilance, right? So that if you do have cases, you can test them. You can do contact tracing like traditional, bread and butter, public health kind of shoe leather to mixing my metaphors to, bread and butter shoe leather. But anyway, to go and take care of it. But other parts of the country, no, we're going to be in for a longer haul. And over the summer, the studies that I've seen, there's a very active research right now on the impact of the role of weather Early studies from China suggested that the weather would not play a major role. That is to say, unlike previous respiratory pandemics, we would not get a summer break. It would maybe a little bit, Now more sophisticated studies are coming out. People are looking around across the world at different countries. The data is hard to interpret. For example, there's an outbreak in the Philippines right now where it's 90 degrees and humid. So, but of course, that's just one country. It's hard to know. I think if I had to summarize that literature as it is right now, I think there will be some modest reduction due to the weather, but not huge and not as big as previous pandemics, which means that the epidemic is going to keep affecting us, through the summer. And in the fall, I think it'll come back I think there's at least a 75% chance we'll have a second wave like we had in 1918, like we had in 57, like we had in 2009 with the H1, second and third waves, and then eventually it damps down and dies out.
Yeah, some of those weather papers came to JAMA to review, and I thought they were just too early in the epidemic to really know. So they produce it early on 2 months ago, and they go, look, there's no disease in the southern hemisphere. And I just felt they weren't realistic.
Well, but China is huge. So the papers that I saw, the early ones from China,
they
took advantage of all of the variants in China.
It was large.
Yeah.
Another question, Nicholas. You and I are in a high-risk category by age alone.
1 or 2% case fatality rate for our age. I mean, that's still a serious risk of death.
That's right. No. It's not like we're older than
80.
Not 80, but I think that's created much more anxiety among my cohort and my friends and colleagues, much more than ever before. As you get older, you want to live a little longer, and then you say 1 or 2%. And, like my children wouldn't travel from New York to visit me. They wouldn't visit me because they were worried that they would make me sick.
Yeah.
Our two boys are the same age.
Yes.
When there's a relaxation in the social distancing, how do you think the different age groups are going to behave? I'm very curious about what your impression is. How do you think people are going to behave?
Well, we have a joke in my family that sometimes when we're having a conversation that little children shouldn't hear, we talk about how we're in mixed generational company. Like the old joke about mixed company, men and women. We'll gender segregate to have a conversation. But we joke about how we're going to be in mixed generational company. We're not going to talk about this because young people are present.
Okay.
So I think there will be some concern about mixed generational company when it comes to coronavirus. Yes, I think that's right. Now, there is asymptomatic carriage of this pathogen. We know this now from multiple studies. So 2 to 3 days. So the latency of the pathogen is shorter than the incubation period, meaning that you become infectious before you show symptoms.
Right.
For 2 to 3 days for some significant fraction of people. So, I think that if your kids come home and you're elderly or even middle-aged, you may want them to sequester for a couple of weeks before they, come into intimate contact with you. This is another reason we need serological tests because, we could test ourselves and see, if I'm immune, then I don't have to worry about my kids coming home, for example. On the doctor front, I think, as you know, I was a hospice doctor for many years, and I don't see patients anymore. I used to see patients until about 10 years ago. Now run my lab primarily. But I was clinically active in Chicago in the 1990s when I was a young doctor, and a house officer at the University of Pennsylvania in the in the early 1990s, and then 1995 I went to the University of Chicago, and of course HIV was very ascendant then. This was before highly active antiretroviral therapy, and if you got HIV, you died. And we took care of patients, and a lot of papers were published, a lot of anxiety about needle sticks and blood. Taking care of patients, you get body fluids on you. I've had every possible body fluid on me: urine, vomit, sputum, sweat, tears, everything, blood, feces. You're a doctor. It's part of the job. And so we were all very concerned about it, but we correctly saw that we had an obligation to our patients and that being a doctor is a calling, and that you have to take some risks and that it is appropriate that we are expected to take those risks. But not without equipment. I mean, we had equipment. So we took the risk, but we had double gloved and we wore our mask and we did what we needed to do. Someone had to draw the blood from the HIV patient and you had to do it. It was your patient. So you went and did it, but you did it carefully with the right equipment. And this is why I'm so upset right now, because it is reasonable and right to expect our healthcare workers to take a risk. It's like being a police officer or a fireman. We expect these people to take risks, but not without equipment. I mean, we don't send a fireman into a burning house naked. We give him an axe and a helmet and equipment and oxygen, and then he or she takes the risk. And water, right, and takes the risk. Or a police officer, he or she has body armor and a gun and, takes a risk, but not unarmed. We don't send them unarmed. And so this is why I'm so upset by the lack of personal protective equipment right now. It's enraging to me that we are in a position where we are. I mean, it's absurd. We need billions of masks and gloves and everything else. And why we weren't producing those the last 6 or 8 weeks defies understanding for me, honestly. I mean, I'm not an expert in medical supply chains by any stretch of the imagination, but I do believe we could have manufactured that equipment if we had been thinking clearly. And I'm sure there were experts in the government who knew about this particular problem, the lack of personal protective equipment, and who were sounding the alarm, in February, saying we don't have enough gloves and masks. Somebody somewhere was sounding this alarm, and that person was not listened to. And that upsets me a lot, because it's here's the thing. I don't know if in early February, I don't think I would have been capable of thinking about this problem, the lack of personal protective equipment. I was thinking about the pandemic. I was aware it was going to come. From my desk, I was studying all kinds of aspects of it, but I'm not an expert in personal protective equipment or medical supply chain. I wasn't. But if someone had told me, like if some expert had come to me and said, Nicholas, let me explain this to you. We're going to have 100,000 people, blah, 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 and each person you have to gown, and this many gowns per hospital per person, and gloves, and blah, 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 and we need 8 billion of these things, and we only have at any given time 500 million in the nation, and we need to produce. I would have said, oh my God, you're totally right. I get it. You're right. Let's do it. It's not a hard, like if you may not think of it yourself, but once someone tells it to you, you're like, oh yes, that's correct. You're exactly right. So why was that not done? I don't understand, honestly. It's a mystery to me.
Yeah, there'll be stories.
Yes.
The great tragedies is we were given weeks and maybe months to prepare from China and Europe, and we have failed miserably. And
I think
at great cost to healthcare workers and to patients. It's nationally embarrassing.
Yes. I think there's no way to sugarcoat that, honestly. I think Howard, you're exactly right. I mean, I don't think we can escape that conclusion. And, we're the richest nation on earth. We have we don't have the best health indicators in the world, but we have the best medical care, I mean.
A couple other questions and then we'll stop.
Yeah.
I'm not quite sure what the role of the WHO has been. They named the disease and, they declared it a pandemic a month ago.
Uh-huh.
Do you have a sense of what their role has been or should have been?
I'm not very knowledgeable about that. I mean, I just read about the WHO in the newspaper. I mean, I don't know much about how the organization functions or its duties or how it's funded. I know that they probably were wary, of jumping the gun. And, I'm sure there's complicated political constraints on them and what they do and what they say and when they say it, and fear of losing their funding if they sound the alarm wrongly or whatever. The reports I've read that the WHO has done, I think, are very professional. So I've read 2 or 3 reports that they've released about the epidemic, including the one that was released a couple of weeks ago. Very detailed, very technically proficient, first-rate epidemiology, just by the numbers, bang, 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 very sort of just the facts kind of thing. And those reports have impressed me. But otherwise, I don't know what the WHO is doing or should do.
I mean, there's been some really remarkably interesting clinical questions. We won't go into them in depth. Tomorrow I'm doing a live stream with Derek Angus around critical care issues. Derek is one of the world's experts. But, you know, the data on serious illness in children is just fascinating. We know they're getting disease or they're getting infected. It's just inconceivable that they're not. And the children's hospitals around the country are not reporting much disease.
No,
any instincts about why that could be? You know, this RAS and ACE enzyme has been of interest. Any instincts about that?
Well, since little children are felled by infectious disease, you know, it's a leading killer. I find it haunting and sweet that they are spared the predations of coronavirus. I mean, I think that is a blessing that in this condition. As many listeners will know, most respiratory diseases have a U-shaped function, right? They kill the very young and the very old.
Right.
And school age and working age adults go out into the world and they bring the disease home and then give it to babies and the elderly who are at the end of the transmission chain. The 1918 pandemic famously had a W-shaped mortality curve with age. So it was the very young, the very old, and middle-aged, sort of working-age people were also affected for a set of complicated reasons having to do with what was happening in the world at the time. But respiratory pathogens generally have this U-shape, but coronavirus, COVID-19, has a kind of hockey stick, and the young are spared. And this has been many studies of this now. I mean, it's quite convincing. They have, a negligible mortality. And now I did some calculations. If you look at the attack rate in the young and you multiply that by the case fatality rate and you multiply that by the size of the population in the United States, you know, a median estimate is that 3,000 young adults, you know, babies to 20-year-olds or 24-year-olds, 3,000 will die. And we will hear about those cases. And but they're a tiny fraction. I mean, the mortality is less than 1 in 2,000 or 1 in 3,000 infected individuals will die if you're young. And that is a blessing, honestly, in this situation.
Yeah, when I'd spoken to Tony on a live stream a few weeks ago, he said, look, there will be case reports of very young children dying, but they will absolutely be the exception. Early on, this was so clear.
Yes, from China, this was very clear, and they published and released that stuff very quickly. And the same thing has been seen in Italy. We're seeing it in our country. It is something about it. And there's a lot of theories, as you were mentioning, as to why, having to do with the nature of the youthful immune system, having to do with the extent to which part of the pathophysiology in this condition is the overreaction to the pathogen. Right. And people are speculating that prior exposure to different coronaviruses in some people, some variation in the ACE2 receptor that the virus binds to in order to enter our cells, that is very heavily expressed in the upper airway, that maybe there's something different about it in little kids, you know, sort of immature, or the distribution. It's not fully known. There are lots of theories about why the young are relatively spared, but they are. And I do think that it's almost biblical. I mean, I think it's terrific, actually. It's a blessing. Even to me, you know, I'm not so worried about my children, who are in their 20s, and I have a 10-year-old as well. My wife and I are not worried about our children getting sick, and that's a blessing.
Last question. We've been at it a long time, but it's so fascinating,
yes,
Nicholas. Thank you. We've just beginning to get opinion pieces about the second wave.
Yes.
That this we'll get to June. Hopefully, we'll figure out how to provide care and get PPEs and testing.
Yes.
We'll get to June. But there is July and August and September and October. You touched on it. I don't know how to brace society or individuals or healthcare systems for it, but there is a fall coming. Any instincts of what that's going to look like?
I think we're going to have a second wave. It's hard to. I don't think it's necessarily going to be worse. In 1918, the second wave was 4 times as deadly as the first wave. In 57, that was not the case. And in 2009, that was not the case. So I don't think it will be deadlier. I mean, I have no way of knowing that. It could be. I doubt it. But I think but it is. We are going to have a second wave, and I think we need to prepare ourselves for that. I'm very worried about the election. I'm worried in 2 ways. First of all, I'm worried that if the epidemic is raging in October, November, it'll interfere with people going to the polls, so it'll affect our democracy. And conversely, if the epidemic is mild and we go to the polls, we may give it to each other. So I would love to see us as a nation protect our democracy by doubling the number of polling places, spacing people out. We're going to need much longer lines. We're going to need to prepare the public that, those little voting booths where we all huddle up against each other and use the same pen. We're going to have we need 300 million pens, so everyone has their own pen, and then it's thrown away after they fill in their ballots. I think we should have absentee ballots and mail-in ballots.
Maybe we vote over 2 or 3 days instead of.
Well, that'll be hard. That'll be hard to change in our country, but there's an election day. But certainly we could do more absentee ballots. And I think those should be paper, because I think the Russians and the Chinese are hacking us. And there's a lot of activity right now trying to sow dissension in our country and actually get us to do the wrong thing so that more of us die. There's a huge active campaign online of misinformation that is really literally trying to kill us by suppressing the flow of accurate information about the epidemic so that we take the wrong steps and that more of us die and there's dissension among us. So I think clear thinking physicians, epidemiologists, scientists, I think prudent planning by our leaders to prepare our public for the sacrifices we need, and careful preparation for our election to protect the integrity of our democracy without politicizing it. Americans need to vote, and they need to vote on this election day. I am very alarmed at what I'm seeing in Hungary, where the parliament recently suspended itself and allowed the president to rule by decree. I think at times of pandemic, it's very tempting to surrender our liberties, and I don't think we should do that, whether it's our liberty of speech, freedom of speech we spoke about earlier in this podcast, or any other liberty like voting. I think we should be, despite facing this pandemic, I think we should absolutely protect our liberties. And that means we need to plan for how we're going to live our lives in a time of plague.
Yeah, we didn't do very well planning for the current period. I hope we do better for the fall.
Yes.
This is Howard Bachner, Editor-in-Chief of JAMA. This has been Conversations with Dr. Bachner, and it's been a privilege to be joined by Nicholas Christakis, who, for our readers, yes, is related to the Editor-in-Chief of JAMA Pediatrics, Dmitry Christakis. They are brothers. Dmitry is a good friend. I've known Nicholas for many years. He is the Sterling Professor of Social and Natural Sciences, Internal Medicine, and Biomedical Engineering at Yale University. Nicholas, thank you. Stay healthy and love to the family.
Thank you so much. Same at you, Howard.
Bye-bye.